Looking at real-world evidence data from quite a few cohorts now, one gets the impression that patients that are treated with CD19 CAR-T cell therapy for relapsed refractory large B-cell lymphoma in Europe do have inferior outcomes when it comes to progression-free survival and maybe also overall survival compared to the real-world evidence that is presented from the US. And that was our initial observation, and we tried to confirm if these differences are truly there. And then the other thing that we looked into was what is the reason, what are the reasons that we can see for these differences in outcome. So we looked at a cohort of a total of 374 patients, approximately half of these patients from the US, from one center, from the Moffitt Cancer Center, and then the other half of the patient from Europe, so 5 centers, 5 European centers, 1 from Spain, and 4 from Germany. And looking at the survival of these patients, we can see that there are very significant differences in progression-free survival. So for example, the percentage of patients that remain progression-free after 12 months in the US cohort, in our US cohort, is approximately 50%, 48% to be exact, and comparing that to the progression-free rate in the European patients is significantly lower, with 26%. And also, the radiographic response is significantly reduced in the European cohort of patients. And that was somewhat troubling to see, because you don't want to treat patients that then fare worse compared to other centers. And we then had a look for reasons why these differences occur. And actually, it's 2 main reasons that we identified. The one most prominent reason is that patients from Europe do have an adverse risk profile for their CAR-T cell therapy. So patients from Europe, for example, have higher LDH levels at a time of indication for CAR-T cell therapy, and patients from Europe also, for example, have higher ferritin levels. And we performed a multivariate analysis where we also included logistical aspects of the treatment, for example, longer vein-to-vein times that we observed in the European patients compared to the US patients. And there were 3 major factors that came up from multivariate analysis to explain these differences. The first reason was response to bridging, so chemotherapy that is applied prior to CAR-T cell therapy, then ferritin levels, higher ferritin levels, and then lastly higher CRP levels in these patients. So this conferred something like a risk profile. And we used a Lasso model for that multivariate analysis. And in that Lasso model, a coefficient is associated with all these significant influence factors or significantly associated factors with progression-free survival. And using these coefficients, you can develop or calculate a patient-specific score. We termed that HR score. And looking at a patient individual level, the median HR score levels in the European cohort are significantly higher compared to the patients that are treated in the US. So that explains one part of the observed inferior outcomes, and the other explanation is the significantly more frequent use of tisa-cel in patients in the European Union. So tisa-cel compared to axi-cel conferred inferior outcomes for us in our cohort as well. And we then used the HR score to develop something like a risk profile and separated our total cohort in 2 sub-cohorts, one sub-cohort with a high risk profile and one sub-cohort with a low risk profile. And when looking at the low risk patients, we can see that axi-cel has significant significantly improved outcomes for these patients compared to tisa-cel, whereas for the high-risk patients, the outcome of axi-cel and tisa-cel is comparable and is comparably unsatisfactory. So the long-term remission rates for these patients with both products is approximately 20%. So these high-risk patients are patients that are in significant need of optimized CAR-T cell strategies to be able to treat, to achieve better outcomes for these patients.